Okay, welcome to week number 9, hip. In this week, we're going to go over classifications like each one. So we're going to go over classifications for hip mobility deficits, which is more like a capsulitis or an OA, power deficits, which is more like a muscle strain, hip pain by itself, encephalopathy, which is insertional pain, as the muscle or tendon attaches to the bone, which is more like a trochanteric bursitis or some type of tendonitis, or hip and leg radiating pain, which is more like a burning or paresthesia pain in the leg. Starting through our exam, as usual, we'll go through a standing exam. We go through a lumbar scan. Can they go through the quadrant with overpressure, without pain? General observations of how they're moving, what their gait is like, the willingness to move, the quality of motion. Then we can do a quick functional test, have them a high step, so you can step onto a high step with one leg, and you're looking for the ability to flex on one side or extension on the opposite side. We can then do unilateral stance. We can do eyes open, eyes closed. Some keys are loss of height, excessive effort. Those are all abnormal. We go through a squat. In a squat, we're looking for the ability of the hips to pass parallel. You're looking if there's not excessive effort. You're looking for the ability of the tibia and the torso should be parallel to each other, at least. Go supine. Palpation. We talk about the lateral and the medial femoral triangle. The lateral femoral triangle on one side has a sartorius, the other side has a tensor fasciolata. Between the two will be where the V comes in. You'll be able to palpate rectus femoris, and if you're really good, you can palpate that up to AIIS, and ASIS is more obvious. From the ASIS, we go to the medial femoral triangle, the inguinal ligament, and the medial edge of the sartorius to the lateral edge of the adductor longus. So we can go from lateral to medial. We could have as it goes over the inguinal ligament is the ilius psoas. Next is the femoral artery, nerve, artery, and vein. Then the pectineus. And even more medial to that is the adductor longus, which is the big muscle that pops out when you resist adduction. And below that, gracilis. The way you can tell if it's ungracilis compared to the other adductors is that you can have the patient abduct into your hand. That'll knock out the adductors. And then you have them try to isometrically flex their knee, which is the gracilis is the only adductor that will show up because it's a knee flexor as well. As we move on with the exam, supine exam, we're going to go through active and passive range. If you want, you can look at a range of motion video, hip flexion, ER and IR at 90, a deduction, make sure you get the other leg out of the way, abduction with the knee flexed or knee extended. Two different ways to test that. Passive accessory, remind yourself, just going to do a little bit of a traction type, inferior directed force. And the key to remember for this one is that you want the patient in a resting position, an open pack, which is a little flexion, abduction, some external rotation. The next ones you can look at the video as well, resisted testing in supine, which is hip flexion with knee flexed to 90. Hip extension, again, done in the supine position as a general idea. The hip extension, you can do a deduction and abduction bilaterally. Special tests you can review by watching each one as a video. We won't talk about them for now. Then muscle length. Then we go prone. The ischial tuberosity is key to find. Get them in that position. You want to be able to try to palpate the hamstrings. So the key to this is have somebody flex their knee about 30 to 40 degrees, resist hip flexion, go to the ischial tuberosity, and follow it. Go on the lateral component of it, the biceps femoris, keep knee flexion and kind of palpate the muscle as it goes down all the way to its superior fibula or superior tib-fib joint or fibula attachment. You can also do the same thing with the medial hamstrings, which have a common insertion at the ischial tuberosity, and follow them down. Next testing, you're in the prone position. We can go back to do hip extension, passive and active, as well bilateral hip rotation, internal rotation. Resisted, you can add bilateral internal rotation, external rotation, knee flexion, knee extension. Passive accessory in this position, Patient prone with the ASIS is in contact with the table. The femoral head is distal to the table. And send the medial side inside of the patient. You're going to push down into an anterior direction. We can do some side bend and side lying. We can also do palpation of those structures. Side lying, we can do hip abduction at 0, 15, and 30. 0 degrees is more glute medius, 15 is more glute minimus, and then 30 degrees with hip flexion with internal rotation is more of a TFL. This week we'll still go over some exercise progression, remind yourself mobility trumps stability. If they had any directional preference where it's really more of a lumbar issue, that goes first. We can do all kinds of mobility, be it neural mobility, be it flossing, femoral nerve stretching, joint mobs, soft tissue mob. And we work through the stability and by position and by surface. So take some time, go through some type of progressions of it. Again, talk about sins, severity, irritability, nature, sensitivities, and stage. So those are key, and discuss with your students options for all those components of it.